They didn't have any status, but behind the scenes we were backing them up. And so what they did is they'd get in a room and they'd have the gynecologists and the GPs, and in the space of 18 months we had 180 different GPs in the room. So different GPs working on the urology pathways or the gynecology pathways or orthopaedics, and they get in a room with a blank whiteboard and say what's not working. Usually we could fill up a whiteboard fairly fast, and then you go, okay, what can we fix? And then we'd fix it. So the next time you had a meeting you could go, well that's been fixed, and that's been fixed, what are we going to do next? What's the next big problem to solve? So it works in a really simple model. It gets things done. We run a line that says it's always got to be better on Monday. So if we're going to roll out a new way of working, it's got to make the clinician's job easier on Monday, not harder, not more complex, not more time consuming. It's got to be easier. And get the basics right. So we talk with people, we focus on what's important, we do what we say we're going to do, we do it when we say we're going to do it. We hold others to account when they say they'll do things, and we do this again and again. And we've been doing it again and again for 12 years. And it's how we keep our system constantly evolving, adapting and engaging. So what came out of that process was a thing called health pathways. Because having changed the health system, how did we tell everybody? We hadn't thought about health pathways when we went into it, but we went, oh, we've just changed how patients flow through the health system. How do we make sure everybody else knows? So we built health pathways. So health pathways are effectively the agreement in the health system about how we're going to do it around here. The agreement between the community-based system and the hospital-based system about how patients are going to flow backwards and forwards. The agreement within the hospital-based system about how patients are going to go around. And we have now more than 700 community pathways. We thought we were going to stop at 350, but we didn't. 99% of GPs will look at health pathways this week. 70% of them will look at it today because it helps them. Nobody has to use it. It is not mandated in our system, but the reality is it takes all the frustration out. And it makes sure that you're never going to again face that circumstance where your patient's going to be kicked off the waiting list. We also have health pathways for consumers, which is called Health Info. So it's been written from a patient perspective. And we now have a health pathways version for schools, which is called Leading Lights, which is written to provide teachers the information they need to recognise when one of their students has a problem, understand how they can respond to it, and then request for help if they need it. So we hold all this together with a shared orientation, a shared outcomes framework. We had to build our own because we couldn't find anywhere in the world that had built an outcomes framework that worked for an integrated health system, that understood contribution rather than attribution. If you're going to make an integrated system work, then you need the whole system working. Because nothing happens in isolation in the health system. And in an integrated health system particularly, you can't deliver the gains we showed you in chronic obstructive airways disease if general practice doesn't do its piece, if you don't have an acute demand program, if you don't have health pathways. All of the pieces come together. So we have this is both our strategic plan and our outcomes framework on a page. Really simple, keeping Canterbury people well and healthy and in their own homes and communities. Subtext out of our hospitals, out of our institutions. And then the measures around that outer circle that tell us whether we're heading in the wrong direction or the right one. So that we can then, and all these measures are live in our system so anyone can see them. So if we know that something is trekking out of line, we can jump on it straight away, figure out what's driving it, and then go back and fix it. We've got a range of services that support people in a community-based setting. For example, acute demand management, that looks after 32,000 people in the year that I wrote this, but it's actually 34,000 people in the last year. Just had a heavy winter. Basically what it is if a patient comes to see a general practitioner, and the general practitioner, because it costs money in New Zealand to see a GP, during most of this time frame, $50 to $65 to go and see a GP. Now, if you have what's called a community services card, which is means tested, then it's $18.50. But up until that only happened a year ago. So I think most people during this time frame were paying $50 to $65 to go and see their GP. If they went to see their general practice and their general practitioner decided they would otherwise send them to hospital, that's the only criteria, they could activate an acute demand program, and the care that the patient got from that point on was free and wrapped around them and in their own home. Now, when we first rolled this program out, the secondary care-based clinicians said, patients will think this is a second-class service, because clearly coming to hospital is the first-class service. I can tell you patients see it quite the other way around. Because when they're in their own home with their own family and their cat and their dog, it's all about them. That service is about them and what they need to keep them well. We also can tell you that the GP, general practice teams that use this service the most have a 40% lower acute admission rate for the over 65 population than the general practices that don't use it. So it significantly makes a difference. We have a whole range of other services. CREST, which is a community-based rehabilitation enablement support team. We've got somebody who likes acronyms. And community rehabilitation, medication management, all of this wrapped around keeping Agnes safe and well and in her own home, out of our hospital. And if she ends up in our hospital, we drag her out. So literally, the community-based services come into the hospital every morning and go, who can we get home today? And they stand in the wards at 8 o'clock in the morning, and we go through the list of the patients on our electronic whiteboards, and we decide, okay, Mrs. Jones can get home this afternoon as long as we get that CT scan done at 12. Actually, why don't we just get her home and organise a CT scan in the community? So they're in there pulling patients out. Because we all know, particularly frail elderly people, are better off in their own homes and environments. General practice is enabled to do a whole lot of things in Canterbury that anywhere else in New Zealand are only done in a hospital-based setting. Things like spirometry, sleep assessments, papal biopsies, a whole range. Infusions, drug infusions, some chemotherapy, a whole range of things that are done in general practice, which is because we have persuaded an entire population that the home of their healthcare is general practice, and we run a telephone triage system in the background, but the message to the population is ring your general practice first. So at 2 in the morning, you ring your general practice and it's answered, Barrington Medical Centre, how can I help you? So our population knows that the only number they need to know is their general practice number. We have ICT to support, deliberately in that order. Design the system, then figure out how to support it with your IT. No, we don't use Epic or Cerner or any of those. We just connected the systems we already had. So our shared health record, which is Health One, Health Connect South is the clinical portal that sits in the hospital-based systems. It's the same one across all 5 district health boards. All 5 district health boards can see Health One. All general practice can see it. All of pharmacy can see it. The private hospitals can see it. Wherever you go in the Canterbury health system, you can see what everybody else knows about the patient. And then we have our electronic request management system, which is actually older than Health One. We built it first, which allows general practice to refer to everywhere else in the health system. And as of January, it will also allow schools to refer to general practice electronically, online, closed loop, constant feedback. 30% of our specialist assessments are delivered virtually. So the general practice refers to the hospital-based system and says, please can you give me a management plan and some guidance? And then the hospital-based system sends that answer back, and the general practice continues to look after the patient. The background of all of this, it's all about data. We use data to drive change, to identify opportunities, to make sure we're still on track. We have persuaded an entire health system that the data can be trusted. So you think about data for clinical care of the patient, that's Health One. Data for running a hospital system, I'll show you that in a minute, which is real time and updates every 5 minutes. And then data for planning, driving service improvement, research, learning, doing new things. Clinically led. So clinicians in the room with the data. This is our general medicine team, figuring out how they can keep the hospital flowing, because they know that if they go over their bed footprint, then surgery's in trouble, so they know they need to keep the people moving through the hospital. We do everything in pathways. That's the way we look at it. Patient journeys through the system, and then measure each point of that patient journey to make sure that we're optimising it and reducing the amount of time that patients waste waiting. That's our patient flow manager in Christchurch Hospital, Nikki. Interesting story. Standing behind, that's all of the screens that are available in the Nursing Operations Centre, which has all of the live dashboard data in it. So she can see everything she needs to know to keep a hospital working. Interestingly enough, she got the flu this year, in the middle of the flu season, and all of a sudden, we lost 6 hours off our average length of stay, because Nikki hassles everyone across the hospital. And with that, those 6 hours that we gained in our average length of stay cost us 60 beds. That's how tight the system is working. So we've actually started to automate Nikki. So we're using our data systems to watch what Nikki does, and then automate those telephone calls to ED, or the telephone call to the charge nurse in Ward 28, which is what she's doing as she watches the whole system to see where the opportunities are for improving flow. So how much more time? Keep going. I'm just going to go, you now know how we did it. I'm just going to have a little look at some other things that you can do when you've got an integrated health system. So we always planned an integrated health and social care system, and we were really lucky, or unlucky, depends on the way you look at it. The earthquakes did a fair amount of damage to the mental health and well-being of our population. They were major natural disasters, and they went on for more than a year and a half. So constant earthquakes. So we have a group of children who are highly anxious, have high tension, didn't get the right start in life. When the government changed, one of their election promises was they were going to address the mental health needs of primary school children in Canterbury. Fortunately, they did come to us, and we said, well, yeah, we think you should do it this way. Their only policy was it had to be 80 FTE mental health nurses in schools, and we went, don't know where we're going to find 80 FTE mental health nurses. We don't sort of have them spare. In fact, we've got a whole lot of vacancies in our mental health workforce. So we said, we think we can do this a different way. And they agreed with us, which was fortunate. So we did it as an alliance. And so as you can see from that picture there, we got everybody in a room. Literally 60 people in a room from across the health and social care system, government agencies, non-government agencies, everybody. Schools, obviously, principals, teachers. And we designed a system. What we were seeking to improve was wait times for services, communication across agencies, manage that system complexity. It was all about Maya. That's Maya in the middle there. How do we support Maya in the context of her whānau, which is her family, in the context of her school, in the context of her community? So we designed an alliance model that uses 13 NGOs who work across 216 primary schools in clusters. So each cluster of primary schools has a group of NGOs working with them. So the teams are all mixed across the NGO organisations. We got the sign-off to go in February. So we got told about it in December. We got the sign-off to go in February. We had the prototype on the ground in April. We started the formal rollout in July, and by April next year we completed 216 schools. In that time frame, we looked after 2,500 children. Since that final rollout, which we finished in April, we've looked after another 1,500 children. So we actually managed to get this whole program running and delivering for children in that kind of space of time because it was an alliance. And because we had service expectations, not service specifications, and we all collectively made it work. When the terrorist attack that I'm sure you heard about happened in Canterbury in March, that happened on a Friday. By Sunday, we had reorganised how this program worked across all of the schools that were most affected by the attack. Most of the schools were affected because everybody went into lockdown, so you've got a lot of children locked in a classroom for hours with stories about somebody running around wanting to shoot them. So we had a lot of unhappy children, but we also had a lot of children who'd lost friends, family, who'd been affected directly by the attack. So we redeployed our workers across the most at-risk schools, and we changed leading lights so that all of the advice was there for the teachers on Monday to know precisely what they needed to do to make the best possible outcome for their children. This is the kind of difference we have seen. So 80 FTE, 290 schools, 2,440 children in the first 12 months, a 76% positive change in attendance, a 79.7% positive change in engagement and wellbeing, and a 64.7% improvement in learning and achievement. That is measured using the education system's measures of those things, not ours. So pretty exciting what you can do. What's kind of more exciting, we built it in a particular way, but I'm going to go straight to this. This is what people say about the program. Working this way has helped strengthen the capacity and skills of the workforce. Thank you for outstanding work you're doing with our tamariki, which is Māori for children and their families. We learnt a lot about emotions. I put myself in other people's shoes. She's grown tremendously, how confident she's become. Our local talkback host asked people to write in on his Facebook about what they thought about Manaaki. Here's just a selection of the responses. There were only 3 negative comments, 2 of which were clearly quite confused because they said things like, well, you know, you're not providing lunches in schools. And it's like, not kind of what we're intending to do. But these are the kind of comments that people were spontaneously making on Facebook page about how much a difference this program makes to them. For those of you who don't know, which I wouldn't expect most of you do, Manaaki, because we don't want to put mental health workers in schools. That doesn't send a very positive message. Manaaki means stronger for tomorrow. So the whole focus of this program is resilience. And it's completely customised for that child in the context of their family. If our workers have to turn up at 7 o'clock in the morning at the person's home to make sure the child gets lunch and has breakfast and gets out and helps the mother learn how to best look after their children, then they'll do that. If we have to get the mother counselling, we'll do that. It's actually whatever it takes to improve the outcomes for our child population. I did mention the terrorist attack. I don't know if you understand the scale of what went on there. In terms of a mass shooting event, there's only 2 in the United States that have exceeded the scale of what happened in Canterbury. And it happened where there's only one hospital that takes patients. They all came to Christchurch Hospital, and the mosque that was first attacked is literally 5 minutes walk from Christchurch Hospital. So the patients arrived rapidly, a number of them ferried by local passers-by. Of the people who arrived alive in our emergency department, we lost 2. One at the time, and one 150 days later in our ICU. We looked after 50 gunshot victims, and he was using hollow points, so they were very badly damaged. And the entire system pulled together. One of the things we did that's, again, a classic, how do we solve this problem? We had an entire Muslim community who wanted to bury their deceased. So there were 50 deceased as well, so 100 altogether that we're dealing with. There's a process that you have to go through in a mass casualty event like that, particularly one that's going to become a subject to court action. So they needed postmortems, and we're going, if we do 50 postmortems, we'll be waiting weeks for burial, and the Muslim community is not going to tolerate that. So what we did is, and what our staff did, is they came up with the idea of CT scanning every one of the deceased victims so that they could identify where the bullets were, so that the pathologist could go straight in and get the fragments, so that we could get the whole thing done that much faster. So over the weekend, Friday is when the attack happened, over the weekend we had 50 deceased victims go through our CT scanner. We had to finish it by Sunday because we needed the CT scanner back on Monday morning for oncology, and it had to be cleaned down and blessed. It meant the first bodies were released on Wednesday, and we were able to get all of the deceased victims back to their families by the end of that week. So again, about a different way of looking at the world and being absolutely focused on what our community needed. So first, some final thoughts, our learnings. Have a shared vision. It has to be simple and straightforward. In our case, it's keeping Canterbury people well and healthy in their own homes and communities by having a connected system that's centred around people, that aims not to waste their time. The future is in collective impact. It's about housing and employment and education, and it's about all of us choosing to work together. It's about collective ownership. The reason that the Canterbury health system works is because it's our health system. If you come to Canterbury and you meet people, that you ask them who they work for, they'll go, oh, the Canterbury health system. They won't tell you which organisation because they belong to the whole health system. It's about having a clear direction, a shared orientation, a true north, that we know that's where we're going. It's about agreeing how we're going to invest and disinvest the money. It's not about people holding on to their budget, but people collectively agreeing this is the best way to spend our resources. It's about using data and sharing it and making it available to everyone. So all of our clinicians have access to our data, whether they work in the public hospital or the private hospital or they're in general practice. They can all see the data, they can all have analysed the data, they can all use it. And that co-owned coordination is absolutely critical to make a system that agile. Literally, we can change the pathways in an hour. We usually change them overnight. So they're refreshed every night, which means everybody knows they're right. And if they're not right, there's a send feedback button in the corner, and you just send feedback and say, look, this pathway didn't work, or this telephone number's wrong, or we need to fix this. So we all know, we all collectively take accountability for making our pathways right. The last thing, high trust, data integration. So we have a purpose use matrix that says this is who's allowed to see what data at what level of granularity to deliver the outcomes we need to deliver for our population, and we monitor it, we measure it, we audit it, but we trust it. So we have 1.1 million patients in our shared health record. It was an opt-off record. About 400 people since 2012 have opted off. So most people trust the system. Of course, if they ask, they can have a list of everybody who's looked at their record. We do have a few patients who do ask us every month, but most people don't. Some last thoughts. It's a way of working because it's got to survive all of the times that we keep on restructuring health systems. So we deliberately designed it to be about the front line by the clinicians, because the clinicians are always there, and about enabling them to own and drive a system change. It drives change based on what's the best care for the person in the context of their family and in their community. And it works irrespective of the structures. It doesn't matter how you organise the system. You can actually drive this way of working, and it continues to adapt and evolve. A Māori proverb, what is the most important thing in the world? E haha te mea nui o te ao. Hei tangata, hei tangata, hei tangata. Whatever you do, IT systems, infrastructure, all of the tools, everything else, it comes back to people. It's always about people. And you need to accept that health systems work on relationships and people. So to make health systems work better, you get used to having everybody in a room, and you're building relationships and understanding, and people learn to work with each other. And one final thought, because This is in your hands. Never doubt that a small group of thoughtful, committed citizens can change the world, because indeed it's the only thing that ever has. Thank you.